because I don't know what I'm doing. Okay, great. Okay, Michael, can you confirm again that we are good to go?
We are good to go.
All right. Well, thank you guys for being patient with us. Sorry, we're still a little bit on spring break here at Carroll PMC, as I am sure that you all are as well. But anyway, welcome to our 6th meeting of 2021. This will be our 17th meeting. I've lost track total. Today we have a really great guest speaker, Dr. John McKenna, and we're going to be knocking ourselves out today, pun intended, with anesthesiology, because that's the type of doctor he is. So today's agenda, since it's on Zoom, it's pretty simple. We're going to just go through some quick opening messages, and then we're going to get right into the interview. Right afterwards, we're going to have questions for Dr. John McKenna. So unless he says otherwise, if you guys could just keep your speakers or keep your microphones muted during his interview, and then afterwards, feel free to ask any questions you want. Also, feel free to type them in the chat as well, and we'll direct him to the chat after his interview and presentation so he can address those questions as well. And then we'll finish off with our next meeting topic and some closing remarks as well.
All right, just to confirm, can you hear the audio?
Yeah, I can hear you. You're all good.
Okay, just want to double check. All right, so before we begin, something we always start with every meeting is we're here to inform, excite, empower, and involve each and every one of you guys. And the 2 questions also to keep in mind that I proposed in the beginning of the semester to keep in mind throughout the meeting, but also during this semester is, why am I here and why should I care? For these questions, you should be able to answer them during our meeting and after our meeting today. And we understand everyone's schedule is busy, so by the officials using the involve, excite, empower, and informing model, and the members keeping these questions in mind, we'll have a successful meeting. So for the COVID-19 community update, since our last meeting, there's been an increase in total cases compared to the recent weeks, with numbers jumping from 98,799 to 100K in Montana. County numbers have currently decreased by 74 from our last meeting. Total deaths increased by 15 in the state of Montana, with 1 being reported from Lewis and Clark County. Additionally, some important information is there have been some rumors and some discussions going around about Carroll possibly hosting the Whammy Summit next year. And what that is, it's a conference for pre-medical students. It has been previously hosted at MSU or U of M. If you have any questions about that, I'd be happy to answer that, or any of the officials would after the meeting. And then additionally, as I had presented last week and the previous week, it's good to keep up to date on the vaccination eligibility, and the website I highly recommend reviewing, and just to spread the word and information about, is the Lewis and Clark County Public Health COVID-19 Hub, and the link is there, and it's really easy to look up, and it will provide all the details there. And without further ado, I'd like to welcome our guest speaker, Dr. John McKenna.
All right, thanks for having me. I was pretty flattered that you guys asked. It seems like not that long ago I was in your same spot. It's been 10 years since I graduated from Carroll, which is crazy. Some of the best years of my life for sure, so enjoy it while you're there, but thanks for having me. I'm happy to talk about what I do because it's a great field. It's one that not a lot of people get a lot of exposure to before, even during medical school, unless you do a special elective in it. But it's an awesome field, and I choose it 10 times out of 10, so I'm happy to talk about it. You can go to the next slide. So just a little bit about me. So I was born in Spokane. Born and raised here. My dad was a doctor, so I traveled a bit. We lived in Chicago for a few years when I was really young for his residency, but essentially lived most of my life in Spokane. I went to Gonzaga Prep, went to Carroll, graduated in 2011, and then I pretty much went straight through. I took a bit of time off in medical school, so the dates don't exactly line up, but I pretty much didn't take any real gap years and just went straight on through. Was lucky to to get accepted to Georgetown, graduated in 2016. And then for anesthesia, you do a separate intern year and then anesthesia residency. So I did my intern year in Boise, Idaho. I did a program at the VA there before going on to Portland for residency at OHSU, where I just finished up this last summer. And I currently am back in Spokane, very happy to be back home. I work for a great private practice. I'm married. This is my wife over here, Nicole, who I actually met at Carroll. And then my 3 lovely daughters. I have Chloe is going to be 7, Emmy's going to be 5, and Josephine is 3. Next slide, yeah. So before college, I tried to answer most of the questions that got put on the slides. If you guys have anything that you want to ask, feel free to ask as I'm going along. I don't mind being interrupted. If I ramble on, you can interrupt as well. So like I said, grew up in Spokane, lived pretty much my entire life before college there. I really never pictured myself doing anything besides medicine. Like I said, my dad was a physician. He's an OB in Spokane. My grandpa was an OB as well, and they practiced together. And not necessarily wanted to be that specialty, but I just never really pictured anything else because I kind of just grew up around it. And, once I realized, professional sports and stuff weren't in my future, which was pretty early on, I kind of focused more towards medicine. Not like really gung-ho super early on, but I kind of knew it's what I wanted to do. The lessons I learned growing up, there's several that I learned that kind of translated well to medical school and beyond. School was always a priority in my family. We always did our homework before we went outside to shoot hoops or watch TV or whatever, so it was really important. Always encouraged to just do our best in whatever we were doing. I played sports growing up, did Boy Scouts. You learn a lot of discipline and self-motivation and a lot of things that are really important to carry through the long, tougher days of pre-med, medical school, and residency, things like that. And as far as my experiences, I really got led there just by nature of how I was brought up and the environments. But, I did do some shadowing in the ER and some volunteering in the ER when I was in high school and things like that to get a little exposure. But most of it was really later on. I did the hands-on stuff. And like a lot of people, I had no idea about anesthesiology. It was never anywhere close to my radar. It really wasn't until towards the end of medical school even. I just knew when we visited my dad at the hospital, the anesthesiologist had a call room by his and they kind of worked together. That's really all I knew about it. So it's tough to kind of to figure out before you get later on in your training. Next slide. Undergrad, so a couple things brought me to Carroll. I played football. I was there. I knew I wanted to play football at Carroll. So that was a big thing for me. And then also I knew I wanted to be a doctor. I knew they had a really strong reputation as far as pre-medical school goes. So a couple good reasons to go there. And I definitely wasn't disappointed on either front. I had a really, really good experience at Carroll. It taught me pretty much everything I really needed to know academic-wise to be ready for medical school. Taught me good study habits, challenged me, things like that. And I really couldn't ask for much more. Had really good professors who were really helpful. As far as what it didn't necessarily teach me, there's some things that in medical school is really just kind of like drinking from a fire hose, to use the most common term. It's just really a lot of material, really fast paced, and it's really up to you to keep up. There's no one that's really going to hold your hand to keep you accountable to study every single day and be disciplined. So, you kind of learn that at Carroll still, but it's just kind of another level in medical school. But a good foundation is definitely laid. And like I said, I pretty much liked everything about Carroll. I wish, the wind wasn't so cold in the winter and the food was a little bit better, but besides that, it was a great experience. I majored in biology. That was pretty straightforward. I'm not sure what it is now, but when I went there, I think if you took quant after that, you got the chemistry minor as well. So I minored in chemistry just by taking the one extra class is really the only reason I did it. People that I knew at Carroll, pretty much everyone that wanted to do medical school did the science route, but you definitely don't have to do that to be a medical school. I had music and English and philosophy and all kinds of majors in my class in medical school. A lot of really diverse backgrounds. As far as how to take advantage of your time at Carroll, I think the most important thing is just enjoy it. Like I said earlier, I mean, college happens once, kind of relatively minimal responsibility, a lot of opportunity to kind of just do what you want to do. And so study hard, do well in school, make good connections with professors, and do the research you want to do and things like that, but really just have fun. It really is the best years of your life, and it goes really, really fast. I don't have a ton of college stories that I would like to have recorded on YouTube. I was pretty lucky to go to school before social media is what it is now. So a lot of them are not, etched in history, fortunately. But I had a lot of good times, I'll say that. I spent a bit of time at that house that Dr. McKenna was talking about and had some good times there. It was a good time in college. As far as work goes, I worked during the summers. I didn't work during school. I was pretty busy with football and things like that. So I didn't have much chance to. And I worked just really non-medical jobs. I worked construction every summer back at home. I had one summer I worked at the minor league baseball stadium in Spokane, just hauling beer kegs and stuff like that. And then did some random stuff in my dad's office, but nothing was really medical related. They're all things I still put on my applications because I think having things besides medical things to talk about is really important and people want to hear about it. But they're all good experiences. And then, yes, I played sports. I played football. I was there.
Before we move on, Dr. McKenna, I'm curious, when you talked about the house that Dr. McKenna was in, for those of you who weren't in attendance for that one, when we had an ophthalmologist speak a few meetings back, he lived in a house with a bunch of other pre-meds. So I'm curious, is that house just known for having pre-meds living within it? And did you know Dr. McKenna?
I don't know if there's a tradition of it necessarily, but I think it's just, I'm not sure if a lot of them were friends before Carroll or met during Carroll doing pre-med kind of things. But they all just were a really good group of friends that kind of congregated together and all really nice guys and fun to hang out with. So, but I'm not sure what the deal is with it today. I don't know.
Right. Yeah. That's just very interesting. Like, here that you mentioned that.
Yeah.
All right. We'll keep moving.
Medical school in itself is just really one big challenge. Like I said earlier, there's just a lot to learn. You have to learn it really fast, and it's really up to you to keep up. It's doable, but it's just a big challenge. It takes a lot of self-motivation and self-discipline to really stay on top of things. Especially these days, a lot of your first year and a half of medical school is, the classroom stuff, and a lot of it's online now. And so it's really easy to skip a morning of lectures and then try to catch up. And if you don't get to them later that day, then you're a whole day behind and it kind of snowballs. So it's just a challenge to keep up because there's a lot. You have exam every couple of weeks, depending on how your school is set up. And it's a lot. It's definitely a lot. And then you have to manage that with taking care of yourself as well and going to the gym or going for a run and keeping in touch with your family and friends and things like that. So it's challenging all in all, but it's fun and it's very doable. For me, I went straight from Carroll to Georgetown. So obviously it's a big move geographically, big culture shift from city to city, far from family. I got engaged before my first year of medical school and was engaged with my fiance, now wife, was in Seattle for a year. So we were apart. So that was tough. So there's a lot of challenges personally and school wise, but you get through it and it's very doable. As far as what successes I attained, I think just graduating was a pretty big success. I was definitely not the top of my class. I definitely wasn't the bottom either. I did okay in all the preclinical years and managed to do pretty well on all the clinical rotations and get good reviews. But I think just graduating from medical school is a pretty big success in itself. And then I was lucky enough to match at my top program, so I was really happy about that. As far as daily routine, it really depends on your school and how they set things up. For me, we generally had 3 hours of lectures in the morning. You could go down to campus or you could watch them online when they recorded. I kind of did either depending on the day. But the important thing was just getting it done way or another. And then in the afternoon, we oftentimes would have like small group things or anatomy lab where you'd have to go down to campus for that. And then after that, it's just a few minutes to go to the gym and then have some dinner and then get the studying done for the night. So it's pretty much like just about every weekday and try to get something done on the weekends. But there's still time for fun as well. And I've kind of said this already, but medical school is like Carroll, just kind of a lot more intense, just more to learn a lot more quickly. And I felt really well prepared. I thought I went to a really good medical school. Georgetown has a good reputation. They train you really well. You learn all the science you need to know and get good rotations on the wards as well. But it's, it's tough to prepare for when you're an intern and you're on night float for the first time and you get a page, you don't know what to do, but you don't want to call your senior to wake them up. It's really stressful, even if it's something really simple, and there's nothing that can really prepare you for that. But like I said, you kind of just adapt and you learn as you go. And then choosing a field for me was tough. I always thought I was into orthopedic surgery. I was a former athlete, and that's what all the former athletes did. I did the rotation winter of my third year, and it just really didn't click for me for whatever reason. I liked being in the operating room. I didn't love the clinic. I don't know. It didn't click for me for whatever reason. And I noticed the other side of the drapes in the OR and seemed like a bunch of great personalities. They did a lot of cool procedures, pushing their own drugs and stuff like that. So I kind of learned a little bit about anesthesia just peripherally, and then I did the rotation at the very beginning of my fourth year and fell in love with it. I had a really good time, knew it was definitely right for me, and applied for it and just went for it. So I think you just have to get experience in a lot of different fields and keep open mind with all your rotations as you do them in your third and fourth year. And you'll find the right thing for you as long as you have an open mind, for sure.
Before we get into the post-medical school years of your life, I'm curious because you said you attended Georgetown University School of Medicine, and Georgetown University School of Medicine has a rich Catholic and Jesuit tradition of caring for the sick, specifically for the whole person, the psychological, the physical, mental aspects of being a person, being a patient. And Carroll is a private Catholic liberal arts school, and so I'm curious if any of your education at Carroll and maybe the elements of Catholicism and the Catholic morals and values that are instilled in the education here at Carroll helped you out at a medical school that sort of had the same values and similar mission.
Yeah, I think definitely. I mean, right. I mean, they talked about cure personalis every single day at Georgetown. There's definitely a lot of similarities, and they really did practice what they preach. Your first year, you have a couple days where you go over to the hospital in small groups, and you just practice sitting and just having a conversation with a patient. It's like you can ask them about what they're there at the hospital for, but it's really just about learning how to talk to someone you're not that comfortable talking with in kind of an awkward environment, and just learning how to make connections with people and not just treat them as a diagnosis or a surgical candidate or something like that. So I definitely familiar with that line of thinking. Going to Jesuit high school and then Carroll definitely prepared me really well, and I still use a lot of those skills today because for me it's easy to explain what I'm going to do to put someone to sleep and tell them the risks and the benefits. It's a lot harder when I'm meeting my patient. They already know their surgeon, but they haven't met me, and in a few minutes I'm putting them to sleep and their life is kind of in my hands, and so I have to get them to trust me and really make a connection with them on one of the scariest days of their life. So it's really important skills to learn, and Carroll definitely helped me with that.
Right, and that's a really great point because as an anesthesiologist, we're sort of at that border. You're very close to that point of being conscious, being unconscious, and a lot of people, especially people who identify as religious and who have really strong faiths, those are very sensitive times and sensitive moments. So I was curious how that impacted you. I'm also interested in knowing, just as a physician, built upon these morals and values, where you treat anybody and everybody entirely, where you see religious experience having a place in medicine.
I think it definitely does. A lot of it kind of depends on, your personality, your beliefs, and also where you practice. There's a lot of, like in Spokane, a couple of Catholic hospitals, so obviously there's a big influence there. Hospitals that specifically, for example, they won't do tubal ligations and stuff like that. So you can kind of see the religious influence there. And then you have a lot of patients that will be, vocal with you about it, especially before surgery. They'll say a prayer with their husband who's there, and they'll invite you to stay in the room if you want to, and things like that. So you definitely see it. I am like definitely proud of my faith. I'm a little cautious about, being too upfront with people about it when they're already, you know, worried about other things. But if the opportunity is there, I'm not afraid to talk about it and, use that as part of, calming someone down before surgery or things like that.
Yeah, great
But
way to
oftentimes I'll let them make the invitation, and they do oftentimes.
great, well said. All right. We will continue on past medical school now.
So like I said, I was very fortunate. I matched in my number one choice for residency, which is a really big surprise for me. Anesthesia, how it works is you do 4 years total. Your intern year, sometimes you do it at a different hospital, sometimes you do it at the same program. It just depends on the program. But you do 1 year of either surgery or medicine, or a transitional year, which is like a little bit of it's like a medicine year, but a little easier, like more electives and stuff, not as much just time on the wards. And then you do 3 years of actual anesthesia training. And then after that, there's a lot of optional 1 year fellowships you can do if you want to specialize a little further. For me, I did my intern year at the VA in Boise, Idaho. Boise was a great city. It's a really good program. I like working with the veterans. They're a really good population. Generally, they're pretty chronically sick, so it's really good pathology to see, but really grateful patients. Being at the VA and not at a big academic place, it was maybe twice than a lot of these other places for intern year. So that was nice. I still worked probably, 60 plus hours every week, 60 to 70, and a little more when you're in the ICU, but it was reasonable. But you're still working 6 days a week, and it's a long year, but a lot of fun. And for anesthesia, you have to know your internal medicine really well. We see heart failure, COPD exacerbations, diabetes, all these things in the OR, and you have to know how to treat them acutely and chronically. So it's really important. It's a good year for me. And then anesthesia residency, like I said, is 3 years. Obviously, you're spending most of the time in the operating room learning how to do OR anesthesia. We do months on the OB ward. We do months of like an acute and chronic pain service, where you're learning about managing my outpatient chronic pain or inpatient hospital pain patients. We do months of just doing nerve blocks. You do months in the ICU, months of doing peds or cardiac anesthesia, things like that. So there's a lot to see. You do everything at least twice. But they're early mornings. They're usually there at the hospital by around 6 or 6:30 and stay till 5, 6, depending on the day. So they're longer days. I probably worked 60 some hours a week. Not as bad as a surgeon. It's not as good as a dermatologist, but it was not too bad at all. There's a lot to learn, and it's really, really scary at first going to the ORs the first time that your attending leaves the room and it's just you and the patient. But like I said, for everything else, you just kind of learn and you get used to it, and your threshold for freaking out kind of changes as the time goes by, for the better usually. And it was a great experience. I liked Portland a lot. I loved OHSU. I got to take care of a lot of really sick patients. We did really big liver transplants, heart transplants, lots of other cases, really teeny tiny babies. Really, really good training there. The match for anesthesia, it's, I would say, moderately competitive. There are definitely some surgical subs that are more competitive, like orthopedic surgery, neurosurgery, dermatology, plastics, things like that. Are a very competitive score and research-wise. Anesthesias, if you look at all the charting the outcomes, I think probably it's like at maybe the bottom of the top third of competitiveness. So it's usually the top half, if you look at board scores and things like that. Anesthesia, your scores matter, your grades matter. It seems like unless you're going to a really big name research powerhouse, your research is not as important. It seems like your personality is really important. Anesthesia tends to attract a kind of more laid back, collegial type of person. And your program's really going to want to see that when you interview and things like that. So I think that's probably the most important thing. Once you look okay on paper enough to get an interview, then just being yourself is really important for anesthesia. And it was 100% worth it. Like I said earlier, I would choose anesthesia 10 out of 10 times. It's a great field. It's always changing. I think it's got a really good future. It's a great, great job to have.
Before we move on, I had a question actually. So you mentioned like OHSU being maybe being a powerhouse for.
Michael, I don't know if you're coming through.
Yeah, it's really quiet.
Yeah, okay, it's very quiet. Watch this magic trick.
Okay, give me 1 second. Okay, so the question that I had was, with OHSU, you had mentioned it being the powerhouse in research, or having some emphasis. Um, and I'm sure within your class, you might have had, or within your cohort, you might have had some MD students. My question for you was there any inclination you had toward research during that time, given the resources there, or did you give it any thought during that residency?
As far as if I want to do research and things like that,
Yeah,
I've honestly I've never really been big into research. I didn't really do any at Carroll. I did kind of the bare minimum in medical school. It just like wasn't really my thing. I enjoy the clinical part of things a lot more. So like in medical school, we had to do like a couple of projects to graduate. I did those, but I was never like really involved in big longitudinal projects. And residency was kind of the same way. Once you get to residency, if you don't want to be in academics when you're done or be like really heavily in research, there's not, unless you really, really enjoy just doing the research, there's not a whole lot of point to it. And so for me, like I said, you stay plenty busy with the clinical stuff, and that's really what I enjoyed reading about and spending my spare time learning about. So I did that instead. So not me personally, but OHSU had specific tracks where you could do an extra year that's kind of integrated, where you did research and had big projects you could do. So there's definitely opportunities.
yeah. And in addition to, I guess you said that extra year, I know an opportunity they offer is like rural surgery. Or an opportunity um, for that? Did you find that they had great resources for that, or were there any that interested you?
Yeah, so I mean I didn't do a lot of real away stuff during residency. It was a little tougher with me. I had, my wife and a couple kids at home, had my third daughter during residency. So it wasn't great for me, but there are opportunities, at least at OHSU, and every place is different. For us, we could do international trips to do anesthesia down in Guatemala or over in Africa and all these other places down in the Caribbean. Um, for the most part, a lot of our rotations were pretty structured at OHSU or the VA on campus there, but there were chances to get off campus and do other things like that.
Great. Thank you so much.
Yeah, yeah. So my job, so I work for a private practice in Spokane called Anesthesia Associates of Spokane. I did not do a fellowship. I'm just a general anesthesiologist. So I do a little bit of everything. Our hospital does pretty much everything besides transplants. And the only thing that I don't do is cardiac. So I don't do any open heart surgeries or like endovascular valve replacements, but I do everything else. We do ortho, we do neuro, do some peds, we do OB. We're in the cath lab, we're in the GI suite, we're all over the place. So we stay really busy, have a really good variety of things I get to do. Like this week, I had a day of doing some cardioversions, which take 30 seconds, just one bump of propofol and a shock, and you're done. And I did another day on Tuesday of a bunch of gender reassignment surgeries, and Wednesday I did a bunch of GI stuff, and today I did a bunch of gyne stuff, and tomorrow I'm off. So there's a lot of variety, My schedule, the OR started at 7:30. I usually get there around 7 or so, Monday to Friday, unless I'm post-call or a day like tomorrow where I'm on for the weekend, so I'm pre-call. And then when you get done is really variable. It kind of depends on your group. We're kind of structured in a peel-off system, so everyone gets a number. Number 1 is the call person for that day, and number 20 or 22 gets the shortest room. So some days you're done by 10 a.m., sometimes it's 2 p.m., sometimes it's 6 p.m., sometimes you're working all night. So it's really variable. I would say if I'm not on call during the week, I probably work maybe 45 to 50 hours at the hospital. So it's much better than residency. It's very manageable. I take call on the weekdays, maybe once every 8 or 10 weekdays. We take call from home. Our hospital is level 3 trauma, so you don't have to be in house, which is really nice. I live close to the hospital, so it's easy for me. We take call from home every 6 or 8 weekends. We cover Saturday and Sunday, so it can be really long if you're working a lot both days. But it's nice taking call from home. My group, we're 30 physicians, and we employ maybe 15 or 20 CRNAs. I would say 9 out of 10 times I'm doing my own cases. Have one day every couple of weeks where I'm supervising some CRNAs, so it's a good mix. I like doing my own cases a lot more than supervising, so it's a good ratio for me. But in general, I mean, we stay really busy. We're all over the hospital, running around all day. Our hospital gets a pretty sick group of patients, so they keep us on our toes for sure. I work with great surgeons, great staff, great partners. So it's a really, really rewarding job. You can really make a difference for people and, truly help save lives, which is an awesome thing to do. All right. So some of the questions I got were just kind of about, I guess, just what I do. Like, I don't know, is anyone really familiar with anesthesia and putting people to sleep or any experience with surgery, things like that? Yeah.
You are the first anesthesiologist we've had on here.
Okay,
So
great.
yes, we're on
Um,
basic.
so anesthesia, like I said, it's a really, really broad field. I guess when people think about it, they kind of just think about general anesthesia, breathing tube, things like that, which is one of the more common things we do. So I can just kind of talk about like a basic how I put someone to sleep kind of thing. So for me, I'll get my room assignment for the next day, the afternoon before, kind of look at my patients, and just looking at the cases, you can kind of tell what kind of anesthetic you're going to need to do. There's all kinds of things you can do. You can do a general anesthetic. Maybe they just need some sedation and some local anesthetic from the surgeon. Maybe you can do a spinal epidural to numb them up for the surgery. Do they need a nerve block to numb up their arms? So you can keep them stone cold awake, but numb for the surgery if they're really sick. You can see if they might need extra lines or extra monitoring, things like that. So I'll go see my patient in the morning. We have to, like I said, we're just meeting them for the first time, so we have to do a full history and physical, do a good exam, especially an airway exam, and get consent for the anesthetic. Every medication we give is going to affect a lot of organ systems. We have to have a really good understanding of their baseline physiology. How's their heart function? Do they smoke and have lung problems? Are they diabetic? How do their kidneys work? Things like that. You have to really know it, or else you can really get burned in the operating room. So good history is really important. We do an exam, especially, obviously, most important thing for us is an airway exam. We look at their mouth opening, how much of the back of their throat you can see when they open their mouth, how much space is between their chin and their neck. All these things give us an idea of how easy the breathing tube is going to be to put in. So we want to get a good sense of that and think if I can put it in with a basic intubating blade, or if I needed something with a camera on it, or even do the intubation awake in kind of rare circumstances if it looks really messy. So once we get all the information about the case and the patient, you can decide on your anesthetic, and say for this patient, we'll decide to do a general anesthesia. We think they need a breathing tube for whatever reason. So for any basic anesthetic, there's kind of 5 things that you need. You need amnesia because you don't want the patient to remember their surgery. You need analgesia because you want them to feel their surgery. You need them unconscious because you don't want them to be aware of what's going on. You want to blunt their autonomic reflex because you don't want their heart rate and their blood pressure to spike when the surgeon cuts them. And you want them immobile because you don't want them to move when the surgeon's trying to sew a vessel back together or do anything like that. So those are kind of the 5 things that you need to make a good balanced anesthetic. So when you think about those 5 things, when we're putting the patient to sleep and then when we're keeping them asleep. So some of the common things we do, I'll pick them up in the pre-op area. If they're really nervous, we give them a benzodiazepine like midazolam, which is like an IV form of something like Xanax. Kind of starts the amnesia process. They usually don't remember much after that, and it kind of really relaxes them. We tell patients it feels like a couple cocktails, although I've never had Versed or midazolam before. Once we get them to the operating room, we have to put them on a bunch of monitors. We monitor their EKG, their blood pressure, heart rate, oxygen stats, things like that. Want to get a good baseline of that, and we have them breathe some oxygen for a couple minutes. When we put them to sleep, they're going to stop breathing, so we want them full of oxygen to give you extra time to put the breathing tube in. If you have them breathe room air, they'll start to desat in just 15 or 20 seconds. If you have them breathe oxygen for a few minutes, they can last a few minutes and give you plenty of time if the airway's more difficult than you think. So then thinking about those other parts of anesthesia, we'll give a couple analgesics. Because when you put the blade in their mouth and intubate, it's very, very stimulating if they're asleep. So you want to be able to blunt that reflex. So we give fentanyl, an opioid, and some lidocaine, which is, of course, a local anesthetic that you can give IV and will really help with pain and blunting the reflex of putting the breathing tube in. Next, we want them unconscious. So we'll give some propofol, which works on your GABA receptors to put you to sleep. To keep you immobile, we'll give a paralytic like succinylcholine, which is very short acting, or something like rocuronium, which is longer acting, so they won't move when you're trying to intubate them. And you can see the picture at the bottom. We'll keep those vocal cords nice and wide open if they're paralyzed. And so that will kind of cover most of those 5 things. And then once you're intubated, you can hook them up to some volatile anesthetic, which is the anesthesia gas, and it keeps them unconscious. It somewhat keeps them immobile. They won't remember anything, and it kind of helps to block some of their sympathetic reflexes as well. We'll give things like opioids and paralytics to help with the other parts of those 5 components, but the anesthesia gas does a lot for us. And then we put the breathing tube in. Usually we use a little tool like up in the corner called a laryngoscope. That's called a Mac blade. It's a curved one. Those are pretty good for most airways. Sometimes if there's really small mouth opening or if it's just really messy looking airway, we can use a special laryngoscope with a camera on the end of it to help put the breathing tube in. Sometimes you can use a little flexible fiber optic scope to put it in as well. Sometimes if the patient has a really bad airway that we're really worried about, we'll do the airway awake so they don't ever stop breathing and we don't have to worry about losing the airway, which can be stressful but doable. And there's a couple of videos at the end that I put that you guys can watch at some point. They're pretty cool. Okay, go to the next. And then what? One of the other questions I got was, you're busy at the beginning and you're busy at the end when they wake up, but what about the middle of the case when the surgeon's doing all the work? The surgeons like to tell jokes that the ABCs for anesthesia, it's not airway, breathing, circulation, it's airway, bagel, crossword. I think we just put the tube in and sit down and relax the rest of the case. I assure you that's not completely the case. There are definitely some days we have a healthy patient that's in the OR all day, and there's pretty minimal work you have to do, but that's definitely not the norm. We're definitely busiest at takeoff and landing, to use the pilot analogy that's really common in anesthesia, but it can still be a bumpy ride in the middle. There's a lot of things we have to worry about for the patient. Different parts of the surgery are more stimulating. You have to make sure they have enough anesthetic on board so they're not getting stimulated, but not too much where they're very hypotensive. Have to keep it on their blood pressures and have to start an infusion of something to keep their pressure up. Make sure they stay paralyzed. They have enough opioid on board. If they're diabetic, you have to watch their sugars. To check the field for bleeding, make sure the surgeon's not getting into trouble. You have to worry about post-op stuff, like are they going to get nauseous? Do I have to get medicine now? What's their pain going to be like? Things like that. So there's a lot to think about. There's a lot to do. And a lot of the cases just aren't that long. So there's not a lot of time to get all your charting done and then keep up with the patient and things like that. So we stay busy. And at the end of the case, the patient's still yours when they pack you. So you're back in the OR with your next patient and you're still going to get called about that first one. So you have to do a good job to keep those calls to the minimum. So I guess the question I got in the slides was, the surgeon's working the whole time. What are you doing? I guess, we both have our downtime. It's still different. I mean, I'll pick the patient up. I'll do my full history and physical in the morning, put them to sleep, help with positioning and stuff like that. And the whole time the surgeon's in the lounge because they've already met the patient. And then, they have their PA close at the end where they go back to the lounge, and in between cases, I have to go see the next patient, do it all over again. And so we have different downtime. We both have downtime. It's just different. And we both appreciate that about each other for sure.
I have a question.
Yeah.
So how important would you say communication between the nurses and the doctors and just everyone within the operating room is?
I mean, it's really important. A lot of the things we do are fairly routine and people kind of know what's going on, but things come up and it's really important that you can have the ability to really, be very direct in your communication, and whoever you're talking to can close the loop and really make sure that that they know what you're talking about. It's extremely important for little things. Like today I had a kind of a tough airway and had to tell the nurse to go get something very specific to help me out. And she was able to, because I could point her the right direction and say, okay, I need you to go to the second drawer and grab this. But if you kind of lose your cool and can't communicate as well, it's very tough to do. And then that's just in a very small situation. If the patient's coding or something like that, it's obviously the same thing, just magnified. It's really important to be able to be very direct in your communication and get your point across.
Well, guys, we are at the end of the presentation. So if you have any questions, please go for it. You can unmute yourself. I don't really see the chat. Oh, here it is. So you guys can type questions in the chat if you'd like. Otherwise, feel free to unmute yourself and ask any questions for Dr. McKenna.
How difficult would you say it is to balance your family life and your work life?
It's It's not tough now. I think medical school is really challenging for that regard. My first daughter was born at the end of my second year, like kind of right at the very, like literally the first day of my study period for step one. So it was a really stressful time for me and really tough. And your third year medical school is really, really busy. Fourth year is probably like the peak of happiness for medical training after you match and you can just relax. So it gets easier. So residency is tough, but my wife is very understanding. I'm very lucky. It's kind of all my kids have ever known, so they are used to it. But attending life is much, much better. The hours are better. There's a lot more vacation. Um, yeah, it's tough, but it's definitely doable as long as everybody's on board.
We also have a question in the chat from our treasurer Roman, who asked, "What parts of your job do you feel rural primary care physician, I believe you meant could utilize?" Roman, could you expound upon that a little bit?
Is there any aspects of anesthesiology that a say family medicine or an internal medicine doc out in a critical access hospital could utilize that would be good to do before they're packed and shipped out to, say, an area like Bozeman or Missoula?
I guess it kind of depends on what your role is going to be there. I mean, I think, my job involves a lot of internal medicine. So there's that, like, there's a lot of thinking involved. Like I alluded to earlier, there's a good balance of thinking and doing, but there's a lot of thinking. So I think, I really have to think about how every patient's organ systems kind of interact with each other and what effect a drug's going to have on other drugs they take and other organ systems. So I think kind of thinking about the whole patient and not just getting focused on your one little subspecialty, the orthosurgeon that just wants to fix the femur or the urologist that's just worried about the stone. Kind of thinking about the whole patient is really important for any specialty, but especially something like what I do, like what a rural primary care physician would do. And then as far as just other specific things about anesthesia, when I get medical students, they all want to put in lines and intubate and things like that. And those are all really fun, good skills to know how to do. But as far as something really practical, I think I tell them if you can learn how to bag, mask, ventilate, it's probably the number one life-saving skill you can learn. Because if you can bag somebody, you can keep them alive until someone that knows how to intubate can get there. If you can't, or you don't have a tube, you can keep them alive that way. So for something practical, for anybody, if you can learn how to bag, mask, ventilate, even if you're not a doctor, it's a really, really good skill to know.
And a very controversial one too. We went over it recently in a sort of pre-hospital medicine class a few weeks ago. We held like a little class, just some insight into pre-hospital medicine. That's quite a controversial thing, especially being that we tend to overinflate. Just nationwide, we tend to overinflate patients usually with the BVM. So much so that I think a directive may be changing soon, at least in EMS, to use pediatric BVMs instead of the adult BVM, just because you're overinflating with both the adult and the pediatric BVM. Have you heard of anything like that?
Not specifically, but I could definitely imagine that being an issue. I mean, I've been in code situations where either myself or someone who's not familiar, like you just kind of lose track of what you're doing and the adrenaline's pumping and it's easy to crank that bag, 32 times a minute. 800 cc's every time. It's easy to do. So I would definitely believe it. It takes some practice to kind of learn the pace, I guess. But it's still better than not ventilating them at all, I would say. So
that is true.
Question I had.
It's happening again.
How's it now? Is it okay?
That's good.
Is that better? Okay. A question I had was, you briefly touched on how the experience in Idaho was unique or different than one in an academic hospital. I was wondering if you could highlight a moment or what you meant by that.
So I think the biggest difference between my intern year in like a big, if you did yours at UW or some other place, like OHSU even, a big academic place like that, there's, it's not the big academic institution that has the really huge, research emphasis and things like that. And the VA in general is just kind of a slower pace as far as everything goes. So it just makes everything a little slower, a little less rigorous. And I think the personalities are a little bit different as well as far as the attendings that work at each place. Very good teachers at both kinds of institutions, but I think it's just kind of a different culture at a VA hospital that just lends itself to being kind of a more relaxed environment in general. And that, for me, just the way it worked, translated to a little easier hours and seemed like a little more laid back attendings and co-residents and the people that it attracted to work and train there. There's something to be said for both. I mean, I think you can get good training at any kind of program. I think it's a lot more important the resident and what you put into it than where you are. Like, I think you can learn to deliver anesthesia at any place in the country. What makes it different is what you put into it, really. And that goes for any specialty too.
Great, thank you.
I think there's there's definitely one question that a lot of people have for anesthesiologists, and I think this is something you can expound upon a bit, but what happens if a patient wakes up during surgery? I think it happens to 0.2% of people. What happens in the instance someone wakes up?
So if a patient's under general anesthesia, like I would think it's even more rare than it's super, super rare for a patient to have any recall. There are times when after you intubate, there can be like a lull while the anesthesia gas is kind of getting up to a higher concentration. And that's a time when you can have some potential for recall. Really, really sick patients, all our anesthetics, they vasodilate, so they make your blood pressure low because of that. A lot of sick people can't tolerate that, so we run them on less anesthetic. So you're kind of running the risk of awareness, but it's still really rare. So some sick people are at risk as well. If it does happen, you can kind of know, because if a patient's paralyzed and aware, they'll get really hypertensive and tachycardic, and you can kind of have maybe a hint that, oh, I should get a little deeper. But if it does happen and the patient says something, I mean, all you do afterwards is you validate their feelings and you tell them the situation, and sometimes it's not avoidable, sometimes it's a mistake, but you just acknowledge it and talk to them about it, and you can offer them options for counseling, because it'd be pretty traumatic for a patient, obviously. I think it gets kind of overemphasized in just popular culture, but it's very, very rare, but it still can happen.
How do you, at bedside, assure a patient who is slightly or majorly apprehensive about undergoing the surgery?
Well, we can do it chemically, which makes it a lot easier. Give some of that said, but it's, I kind of have my spiel. I say my consent for a patient is almost word for word the exact same every single time, but you can kind of tell if you get to a certain part of it and they get like kind of a look on their face, what you need to really reassure them about. Some people get really worked about their breathing tube. I tell them, I guarantee you're gonna be 100% asleep the entire time this tube is in. You're not gonna remember it. And so I think just you can kind of read the patient and tell what's really worrying them. You can give them the statistics on, their chance of a heart attack during this case is, so much lower than it was versus them getting in a car crash on the way to the hospital, things like that. Yeah, it's really patient specific though, what they're really worried about.
And on a similar note, does it bother you that your patients don't usually, or a large proportion at least, don't usually remember you?
Not really, no. It doesn't bother me. I mean, I thought I would kind of miss, having continuity with patients in clinic or things like that. But it really doesn't bother me. It's, I get a lot of my satisfaction from, getting a really sick patient through a really big surgery safely. And, I don't necessarily, oftentimes I drop my patients off in the PACU, they're still pretty sleepy and they don't even, aren't awake enough to say thank you, and I never see them again. But it's okay with me. That's just the way I am. My satisfaction comes from not necessarily them saying thank you, but just from knowing that, I got them through this, and hopefully it helps them all out.
All right, does anybody else have any other questions for Dr. McKenna?
A question I had, you had mentioned kind of a mannerism that's commonly said is smooth flight in and safe landing. Something in my experiences of shadowing and questions I've asked anesthesiologists are the liability side of it. And that's definitely on the minds of those who I'd asked. And I was wondering if you could just talk about what's going through your head during certain circumstances where, or I guess the liability side of your practice or your work.
Yeah. So, I mean, you definitely think about it. Obviously, there's a lot that we do that can go wrong. You know, you can have an airway that you lose and you can't get it back, or you can't intubate to start with. Patient can have trouble with that. You know, surgeon gets into bleeding and you can't get access and give them blood, things like that. Or if they aspirate when you're intubating, like a lot of things can go wrong. You definitely think about it. You know, things I do to protect myself. I have, you know, really thorough consent discussions with patients. I don't freak them out, but I let them know that, you know, things can go wrong. It's very rare, but they can. And then I think the biggest thing to do is just make sure everything that you do, and this goes for any specialty, just have the patient and their safety in mind first. You can have a surgeon that's kind of chomping at the bit to get a case going because it's 6 o'clock and they want to go home. They're asking, do you really need this A-line? Do you really need to intubate this way? And you have to be able to stand your ground and say, yeah, I do. It's the patient's best interest. And I think as long as you're doing that and really keeping the patient first, everything else kind of falls into line. For a couple reasons. A, because the patient usually does better if you're doing that, and the team is on board with that. So they just have better outcomes in general. B, if you do get sued or something like that, you can point to, I was doing things by the book. I did a rapid sequence intubation. I did everything I could to prevent an aspiration, but they still did. And, you know, it's a known complication. And then I think also if you have that good rapport with patients and their families and they trust you and know you're going to do everything you can for them, they're also less likely to go after you if something does go wrong. I've had bad things happen to patients in residency, especially, and, you know, patients are pretty understanding, and so are their families, that things can go wrong. And if they know you're doing everything that you could, then what can you do?
And then kind of a follow-up question I had was during your entire guest experience up till now, from your pre-medical years till you practicing, was there one defining moment that challenged you, or you kind of felt that you had to be not necessarily be strong, but feel strong in your decisions?
Yeah, kind of a lot of times. Some are little, some are big. You know, you have to make some tough decisions in the OR sometimes. You know, the first time you have to like run a code by yourself is really tough and really stressful. And it's tough to make decisions in that situation and think you're doing the right thing when it's a long time before help can get there for you. At the same time, in a similar situation, it's kind of tough to decide when to stop running a code and things like that, and when you realize there's nothing else you can do. So those are really tough situations. You really have to draw on a lot of different experiences, both clinically and not clinically, to make good decisions. Yeah, there's probably a lot of times.
Great. Well, we are nearing the end of our time today. So thank you, Dr. McKenna, for the chance to speak about your practice and everything. We really appreciate it. It's been very insightful and helpful for most of us who are interested in going to different fields of medicine and want the diverse exposure. So we appreciate your time. If you guys have not looked at or copied down the links yet, we will send it in a separate email. But thank you so much, Dr. McKenna.
Yeah, thanks for having me. If you have any questions, my email is right there. You can ask anything, medical school, pre-med, anything related, I'm happy to answer any questions. A lot of people help me. I'm happy to give back as well. And those couple YouTube videos are kind of interesting, awake intubations that we can do. They're kind of fun to watch them.
Is there a viewer discretion advised?
I mean,
Or
there's nothing bloody, but it's medical, but it's fine.
All right, just making sure, because I messed up on that a few weeks ago. We had an eye surgery video just pop up right there, and it was.
Oh, yeah, I mean, you'll see like a trachea and stuff, but it's not bloody.
Cool. All right, well, we appreciate it. Thank you so much, Dr. McKenna.
Of course, thanks for having me.
And
Thank you.
with that, you guys, we're gonna just end with our little closing remarks. So, oh boy, there we go. I skipped Michael's message. So I just oh gosh, okay. So I just realized that I did not put a slide in for our next meeting. There's a 50-50 shot we're gonna have a speaker talk about financing medical school and the diverse ways you can do so. Or we might do something in person, possibly regarding international opportunities. But I'm thinking we're probably going the speaker route, but we will confirm that with you guys next week. If we do the speaker route, it will be on Zoom again. So you can join us in your PJs once again if you did that this time.
And to end, the parting message from a famous book, Into the Wild, I think it's also important in relation to medicine and life is from a book, and it's, I quote, and I also know how important it is in life, not necessarily to be strong, but to feel strong, to measure and challenge yourself at least once. So with that, thank you guys so much for attending this meeting today. Hope you took away something, and yeah, have a great weekend and rest of your week, and sanitize those laptops.
You guys have
Thank
any other questions?
Thank
about
you.
anything, you can stick around, but we appreciate your time. Yeah.